Alright, welcome back to Midnight Med. This video will be on aortic dissection. So the classic presentation might be someone presenting with very sharp chest pain that radiates to the back. Sometimes this pain might radiate to the face, arms, or legs. When you do your cardiovascular clinical examination, you'll find abnormal pulses, differences between the arms on blood pressure readings, and when listening to the heart sounds, you might notice an aortic murmur consistent with aortic regurgitation. The type of patient this presentation is most expected in would be older male smokers or younger males with a connective tissue disorder like Marfan's or Ehlers-Danlos syndrome. So how exactly does an aortic dissection develop? Essentially, there's a rupture in the aortic intima, that is the inner lining of the aorta, that allows blood to enter and fill the space. This creates a collection of blood called a hematoma, as illustrated on my beautiful hand-drawn diagram here. This is already a serious situation, but it can later lead to a total rupture of the aorta, which is a medical emergency. Okay, so once we have an inkling that our patient might be experiencing an aortic dissection, we need to perform some investigations. In addition to routine blood tests, an ECG, and an echocardiogram, a CT scan with or without angiography is first-line imaging. The presence of dissection should be fairly apparent here. A chest X-ray could also be informative, although it's not first line. There are two overlapping classifications that are used to classify aortic dissections into types. These are the Stanford and Debacy classifications. When we discuss management, I'll primarily be referring to the Stanford classification, which is why I've put the schematic of the Stanford classification here. The Stanford classification splits into two types, A and B. Stanford A originates in the ascending aorta and can either stop at the aortic arch or go all the way down to the descending aorta, so A for ascending. Stanford B originates in the descending aorta and can go all the way down as well. B for descending doesn't quite work as well, but hey, if it works for you, you're more than welcome to run with it. The Debacy classification splits into three types. Type 1 starts in the ascending aorta and goes towards the aortic arch, and it can extend all the way down. It's basically the same as a Stanford A. Type 2 starts in the ascending aorta as well, but it's confined to the ascending aorta. Type 3 starts in the descending aorta and basically encompasses all of the Stanford B classification. Type 3A is used to classify all those that at most extend down to the diaphragm, and Type 3B is used to classify those that extend beyond the diaphragm and towards the abdominal aorta. As I noted before, treatment is based on subtype. For Stanford A, an aortic arch replacement like a Bentel procedure is done, as noted in the schematic below. Alternatively, a stent might be placed. In the schematic below, you can see the various steps taken to perform the full replacement of the aortic valve, aortic ridge, and ascending aorta. The Stanford B type is typically managed conservatively by managing hypertension and providing pain relief. Stenting or surgery are rarely performed. And the million-dollar question is always, how can we prevent aortic dissection? Primarily by controlling risk factors, quitting smoking, and managing chronic hypertension in particular. That's it, so thanks for watching. Don't forget to like, subscribe, follow us on Facebook and Instagram for more, and we'll see you in the next video.